This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you. This is going to be Chapter 7, Part 2, Administration of Drugs. And we're going to start talking off about endotracheal tube administration. Several medications can be administered through the endotracheal tube. And a nice acronym to remember on this is NAIL or lean, Narcan, atropine, lidocaine, and epinephrine, or LEA, and they still stand for the same drugs, but lidocaine, epinephrine, atropine, and the Narcan. Increases conventional IV doses whenever you give somebody this via the ET tube to 2 to 2.5 times, and the reason being is we're across another cellular membrane where the capillary beds are here, so some of the drug will be lost in this transfer. After the medication is delivered, add about 3 to 5 mils of normal saline to wash the medication into the tissues. Inhalation administration. Medications are administered into the pulmonary system via inhalation or injection. Promotes bronchial dilation for respiratory emergencies. Other inhaled drugs are things like mucolytics, antibiotics, and topical steroids. Pulmonary drug administration via a small volume nebulizer. Patient must have an adequate tidal volume and respiratory rate, or they will not get the medication where they need it. And that means if they are too clamped down or having too much of a bronchial spasm to move air, you might have to assist this via a BVM. And that's what's being showed over here in this graphic right here. And we'll talk about that whenever we hit lab. Meter dose inhalers, handheld devices that produce a medication spray for inhalation. Some meter dose inhalers come equipped with a spacer. The spacer kind of allows a chamber to aerosolize the medication into. So you get all the medication in the parts per million, and then if the patient has any tidal volume, they can suck all of that into their actual lung tissue. Intraosseous infusion allows a rapid vascular access via the bone marrow and used mostly to administer fluids and drugs to children 5 years of age and younger who are suffering from circulatory failure or cardiac arrest. All drugs in crystalloid solutions that can be given administered intravenous can also be given by the interosseous route. Now, some services, including IMSA, this is their primary IV route. This is their primary way of delivering medications perennially during a cardiac arrest in an adult and pediatric. So the Easy IO, and that is a registered trademark brand, gives an easy way to facilitate an IV or an IO into an adult. And that's the method that we're going to be showing or showcasing here in this. Easy IO is pretty much industry standard at this point. So IO insertion, this is 1 of 6. Locate the landmarks, which are about 2 fingers down on the tibial tuberosity. Clean the site. Insert the Easy IO needle set and remove the stylus from the catheter. That's all what you need to do here. So we clean the site. Insert the Easy IO needle set, and what we're going to do is there are graduations, and please look at the skill set again here on this really quick. But on the actual needle itself, it has lines. So be sure that you can see that last line. You're like somewhere, whenever you insert it and touch the bone, that hopefully you're somewhere in here with the skin level, so that whenever you squeeze the trigger on this and it spins it in there, there'll be some needle actually in the bone. Now, if the patient has too much tissue in this area, there are multiple sizes of IO needles that you can use, up into including the actual yellow one, which is for obese patients. Remove the stylet from the catheter. This is important because no fluids flow down this if this stylus is in place. And this assists it going into the bone marrow. This is a lure lock or a standard IV lock. Flush the IO with about 10 mils of normal saline. Be sure that you have a good flow. And start infusion under pressure. Now, most of the time, the easiest way to remember this pressure infusion thing is to blow this thing up until you hit the green. Most of them have a color coding, which is about 200 millimeters of mercury on this. Have enough pressure to actually push any of your medication via bolus in through the os and into the central circulation. Administering medications. Administer medications as you would through an IV bolus on the IO. External jugular access. Receive and write down confirm the order, prepare the appropriate equipment, position the patient supine with the head turned away from the side to be cannulated. So have them turn their head away from you. After locating the vein, prepare the site, apply gentle traction on the vein, approach the site midway between the angle of the jaw and the clavicle, aiming towards the shoulder, and puncture at about a 30-degree angle. Upon entry in the vein, note the flashback of blood and advance the needle and catheter approximately 2 millimeters to stabilize the needle into the vein or into the lumen of the vein. Remove the needle and properly dispose of the sharps container. Connect the intravenous tubing and slowly open the fluids and allow flow. Confirm that the flow is flowing freely without evidence of any infiltration. Confirm and document the successful completion of an infusion. Monitor the patient and report any changes. Pretty simple. Position the patient. If you're on this is the patient's left side. So we can see our target here. So if you position yourself here on the left side, this guy's kind of positioned in the middle, but it gives you easy access to the external jugular. Turn their head and cleanse the area. Occlude the venous return just above the clavicle. So what that's going to do is blood is flowing in this direction. So it's going to kind of puff up that vein a little bit. It's just like a tourniquet, only you cannot apply a tourniquet to the neck. Insert bevel up, and this is a large 14-gauge angiocath, shown here. Do not start down low. The lung is probably somewhere around here. Needle that long. If you started down low, insert it into the area, and let's say you got outside of the vein, you got into the actual tissue, you could easily pop their lung. So stay up high, somewhere in between the ear and the clavicle, about midway is where you're going to want to start aiming for this. Enter the external jugular. Again, I'm going to back up one here. Whenever you enter the vein, let's say that this is the vein and that's your needle, bevel up. You're already in the tissue. Whenever you enter the vein, enter into the vein and you know that you're in there. Should run that kind of the size. Drop the level down of this a little bit and insert the needle just a little more so that you're definitely in the lumen of this vein, and then thread your catheter. That's the easiest way to always confirm and get a better chance at having successful IVs. Enter the external jugular, and then finishing up the external jugular, confirm placement, set the IV flow rate. Start off kind of slow. You're running it into their neck. Document the procedure and any changes as necessary. This is a quick skill review of an epi auto-injector. This thing almost takes care of itself. Perform a thorough patient assessment and history. Confirm that the drug is actually needed and the patient does not have any allergies that contraindicate the use of the drug. Receive, write down, and confirm the order and explain the procedure to the patient. Examine the auto-injector for name, dose, and expiration date. Remove the safety cap from the auto-injector and place it on the patient's outer thigh. Press until you hear the auto-injector function. Hold in place for approximately 5 seconds. Gently massage the injection site for approximately 15 seconds. and then monitor the patient and report any changes. So explain to them what's going on. You're going to use an auto-injector on them. Remove the cap. Place the epi on the lateral mid-thigh. Now this needle is going to shoot out of here under pressure and enter into the actual intermuscular area of the patient. Press it firmly to activate and hold it until all the medication is delivered. About 5 seconds should be appropriate. And then dispose of the actual auto-injector at that point. Pediatric drug administration, very simply, pediatrics are weight dependent. So never give an adult dose to a pediatric patient unless they are adult size. Now, as we get further in the curriculum, we'll start to talk about 100 pounds as a cutoff or puberty whenever we start to consider them adults. If you ever exceed something called your Braslow's tape, then by all means, and it's a weight-dependent base tape, by all means give them the adult dose. Standard drug dose is nearly non-existent in children, and this is because it is weight-based. Adult metabolizing parameters start at puberty. Renal excretion decrease under 1 year of age. During childhood may exceed that of an actual adult. Drugs are generally ordered according to the patient's body weight. So on any pediatric administration, they're going to be weight dependent. Geriatric drug administration. They are very sensitive to the drugs. They don't make as much protein. Their liver doesn't function as well, and neither do their kidneys. So the elimination route and the biotransformation routes are kind of impaired. And they decreases in drug metabolism occur, poor distribution in the body, and poor renal excretion. And they get adverse reactions are largely dose-related. And that's because it's the gift that keeps giving. They can't biotransform it. It creeps in there, and then once it's in there and it's active, it actually is extended and stays in their system for quite a while, longer than we would actually think. Bodily fluids, infectious materials are present. They may not be any signs or symptoms. Contaminated sharps and equipment disposal. Slow down. Don't get in any hurry. Immediately dispose of any used sharps that you have, and avoid recapping any needles. In conclusion, a strong knowledge base in medical protocol and the routes of each medication is essential. In an emergency, the EMS professional is required to quickly identify the drugs to be given, the necessary dosage, and the most appropriate route. It is important to build a knowledge base that allows comfort with the protocols and the drugs administered routinely within the EMS system. Practice and prepare extensively to be able to administer drugs in a safe, rapid, and systematic manner. References for this were taken primarily from Beck's Pharmacology, EMS provider Del Mar Learning, and Bledsoe's Pre-Hospital Emergency Pharmacology 7th edition. Also from O'Keefe Michael, Emergency Care 12th edition by Prentice Hall. Graphics are from various websites that were used in this slide set. And if you have any questions concerning this chapter, feel free to give me a call. My name is Roy Smith, smithr@imsa.net, or 405-219-7613. Thank you.